Okay. Well, good afternoon, and thank you again. Good afternoon, and thank you again, Gwen Darian, for that introduction. I'm excited to be here talking to you all at your Innovation Summit, Achieving Health Justice. I feel like I know a little bit of something about that, so thank you for giving me your time. So I'll start with my journey from pediatric surgeon to presidential appointee back and beyond. And as you can see on the left, I'm a pediatric surgeon, and I trained 9 years after medical school, or 18 years in total after high school, to operate on preterm infants, even infants still in utero, to improve their lifetimes. And then somewhere after COVID, was appointed by President Biden, and then opening an ambulatory healthcare center. I believe all of us have a before COVID story and after COVID story of something they were different, something they were doing different. And for us in the city of Philadelphia, I went from being in the operating room to being in a church parking lot. In essence, with the work we did, it was reported by Bloomberg News that we had vaccinated more Black Americans in the city of Philadelphia than any other city with greater than 500,000 in the United States. Now, you might ask, how, when, why did that happen? It was in essence because people were reaching out to me and calling me to say, Ala, I believe I have COVID. I went to my doctor. I went to the ER and I was sent home, that I wasn't sick enough, or that because I took a bus and they were only testing people who were in cars, that I couldn't be tested, or because I had a prescription, but my doc wasn't on staff at that particular hospital, they wouldn't test me, or because I wasn't over 65, I didn't work in a healthcare environment, that I did not meet criteria. And after reaching out to local, state, and federal government and realizing that nothing was happening immediately, that I was going to be the one to help and care for people in these communities. And being a physician scientist, I went to the phila.gov website. I pulled up the zip codes where the positivity rate was the highest. I knew that Black people use the church, or it is a staple and a place of trust. And so I asked my pastor to reach out to pastors and in these zip codes and ask if I could use their parking lot. That all I needed was that space, that I would build the triage hospital there, that I needed electricity and restrooms for my team. And that's how we got started. And all of the invoices for the test, I had them bill my practice so that it was barrier-free and no one received a bill. And that's how we tested more. And that is how we subsequently vaccinated more and decreased the death and disease in Philadelphia. So when the vaccines became available for folks, I went to my health department. I said, we are ready. We have a well-oiled machine. We are testing up to 800 people a day. We have licensed doctors and nurses, and we're ready. And the health department said to me, Dr. Stanford, we can't afford to give you the vaccine because Black people don't want it. And I said, that narrative is not true, but I couldn't do anything about the fact that they weren't going to give it to us to give in these communities. And then I learned that they had actually given the contract to a group of young, and I have nothing against young entrepreneurial folks, but young non-medical people that came up with a great idea and presented it to the health department and said, we can do it. Well, they weren't medical and they didn't have the medical expertise, and the people who were part of it left, and ultimately they were shut down. And they were shut down because they were doing all sorts of illegal things. And this became a national story. And so the New York Times talked about it. Of course, it was in the Inquirer and others. And because who the city had invested the majority of the finances to do this job, to take care of all Philadelphians, not just Black, who were 3 to 4 times more likely to contract COVID and die from COVID, we became the vaccination, mass vaccination unit in the city of Philadelphia, where people could go to get their vaccines barrier free. And I mention this and I tell this story because, one, it happened. And two, when people say I don't see bias and I don't see systemic unfairness and institutionalized practices, this was one that happened not long ago. It was actually 3 years ago. And how we were able to ultimately vaccinate and assist the city and assist the academic medical centers, I had to fight for that. And we were not the first choice, even though we were doing the work and our proof was in the concept. And so after we started taking care of everyone, I didn't know how we were going to manage all of the people coming in every day. And so as a surgeon, I said, you know what? I'm used to working 48 hours at a time. We're just going to be open for 24 hours. And that's what we did. And we were at the Leah Center. We outpaced the city of Philadelphia. You can see in terms of vaccinating the group that was most vulnerable, and I'm calling them most vulnerable, the ones that were disproportionately dying and being hospitalized at a higher rate, which were the Black Philadelphians at the time in Philly, and recognize that we were vaccinating people who, one, people thought did not want to be vaccinated, and two, that we were doing that at a higher rate than all the other providers in the city at the time. And this was just another opportunity to dispel subjective narrative or folklore with objective data. And that has been a mantra and a lesson that I live by in achieving health justice. And so remember I mentioned that all those folks were being turned away because they were uninsured or underinsured, or their doc wasn't on staff, or because a parent could bring a child and they were only testing children, or vice versa. So the revenue that I subsequently generated when the CARES Act was passed, because I had seen thousands and thousands of people for testing that I was able to submit a claim for, that revenue I generated, I put and I built the Dr. Ala Stanford Center for Health Equity. And it is in one of the lowest life expectancy communities in Philadelphia, where health disparities are rampant. And our goal was to put an expert center in a location where people live and work and play, that they could walk to and receive that care in their community. These are some of the services that we provide. So after we started with the center, we're offering primary care. And then December of 2021, we had a peak again. And all these folks you see here lined up on this campus are all waiting and wrapped around the building. And so it was like PTSD for me and my staff, that we were seeing all these folks come back again. Like, what did we learn last Christmas time? And so I posted something on X and I said, White House COVID response team, where are you? You know, this is happening again. And you can see down here, the folks are wrapped around, and that's the front of the center. And I literally got a call from the White House saying, Dr. Stanford, how can we help? What do you need? And with that, I led a FEMA mission. They sent personnel, both clinical and non-clinical. And our goal was to go into Philadelphia public schools, because now the positivity rates were increasing in our schools, vaccination rates were low, and we doubled the vaccination rates in many of those schools. And again, saved lives of our young people. And after that, I was asked if I would serve in the United States Department of Health and Human Services. And you can see here, I was excited about that because now I had an opportunity to be adjacent to and work alongside decision makers passing policy and legislation for best health outcomes in health justice. And I was able to bridge what was happening at a grassroots level to a federal level. Definitely one of the highlights of my career. And in the midst of all of that, I wrote a book. And you're thinking how and why? There's a couple reasons. One, someone asked me once where I was from, and the area that I'm from is impoverished. You know, Philadelphia is one of, if not the poorest city in the United States. And I said I was from North Philadelphia, and they were aghast, like, really? You're from like, somehow it was improbable that I could have accomplished many of the things that I have and be from North Philly. And I said, I need to write that so people can see that there are roses that come from concrete, and I'm an example of that. And also for those who are living in dilapidated conditions, to see that where you start is not necessarily where you finish. And the other was that we needed to chronicle so many of the things that happened during COVID and beyond to show that it was really triumph over tragedy in certain ways. And I wanted to, while I have this platform, to use my story and my narrative as an example of some of the barriers that happen when you're training to become a pediatric surgeon, some of the barriers when you are just going through college and med school and residency and fellowship and doing research that not everyone faces, and people don't tell because you're just so happy to have made it that you don't want to talk about some of the challenges. But I used my own story. I was very vulnerable in sharing it to put it out there to be inspirational as well as educational. And then the last part is I really look at it as a DIY or do it yourself for equitable care in our nation. And so when people ask me, how do we get to equitable care? How do we achieve health justice? I say, it's the title of my book. And it doesn't matter if you're clinical, if you are a bureaucrat, if you are working at an insurance company, if you are the front desk person, how are you treating the person across the table from you? Are you taking care of them like someone whom you love, like your spouse, like your child? And if you're not, that's where we make the inroads. That's where we make the change, is we take care of people like our own. And I was recently at an American Academy of Pediatrics meeting, which is like the largest governing body of pediatricians in the United States. And this was one of the books for sale. And I was so excited to see it because, in essence, they're saying that racism impacts your health outcomes, so much so that I need to teach you as a health professional how you address it, how you come face to face with your own bias, and how you untangle it and how you dismantle it so we can first do no harm and give our patients the care they need and deserve. Everyone talks about the social determinants of health. We're teaching it as undergrad to undergraduates, to medical students, and we talk about these conditions where people live and are born and where they work and how they impact health. But most times people say 90% of what happens to you happens outside of the hospital, and only 10% happen in the four walls. I am one who disagrees with that. I believe in my book, I have lots of evidence to support that. And I believe it's closer to 50-50, that as healthcare providers, we can do more to get to the best health outcomes, to eradicate health disparities, especially when we acknowledge the bias that is part of the care that we deliver, not just personally, but all the ancillary staff and team around us. And we get to that. Some even report if you removed bias from healthcare, it would improve health outcomes by 20%. Again, it's important to know the social determinants of health, but not to say, well, this happened because of something outside. But we first look within to see, are we part of the solution or are we exacerbating the problem? I wrote about many things. This is 11 years ago when I was talking about malrotation and midgut volvulus, expecting that the surgical outcome would be worse for Black children. But what I actually found is that it was worse for Latinx children. And when I presented this data at national meetings, people looked at me like, oh, that's not true. And so it's a good place to be now that we are discussing these things, that you would invite me to talk about health justice in this space. But now people are looking to say, this is real. Representation is so critically important. When I was in medical school, this was closer to 5 to 6%, which is still very low, but now it's less than 3%. And so when you no longer have affirmative action, it makes it more challenging. Our historically Black colleges and university are training more Black doctors than anyone else, and they're the minority in terms of medical schools in this country. And it's not just about so someone can have a doctor that looks like them. We now know that in counties with Black doctors, that people live longer. It's a cultural understanding that someone of color will bring into the room that makes you look at a patient labeled as non-compliant and sees it through their eyes, that maybe will have you change the way you present your information and your treatment algorithm, so they will be more likely to be able to follow it. And as a pediatric surgeon, when this was revealed, and this was for over 100,000 children, healthy kids, healthy Black children, healthy white children, but our Black children are more likely to be readmitted, more likely to have complications, and more likely to die with the same operation. We have work to do. We, and I say we as surgeons, as nurses, the people within the four walls of the hospital. And that is true as to why I say it's not everything that happens outside. When they're in the building, there are things that we can do to reduce this statistic and these data. So in the midst of all of that, the University of Pennsylvania recognized the work I was doing and said, we need you to teach our next generation. We also need you to teach and collaborate with our staff and professors. And so I'm excited to be at Penn, at a place where we're looking to solutions to problems that historically have not had a solution, and really passing the baton to the next generation. And in that role, I am also the Director of Community Outreach in the Institute for RNA Innovation, and working in the Annenberg School for Communication, because how we were able to effectively communicate during COVID was, I don't know the right adjective. Sometimes it's hard to come up with adjectives for work that you're doing, but how it was presented to me from the dean was effective. It was effective what we did. And so how can we take what we were able to do during COVID and bottle it up and personalize it, if you will, for different populations, so that we can be more effective in our communication, and that communication leads to best health outcomes. I'll be teaching the intersection of biology and health as a freshman seminar in January. I am super excited about that. We're going to have some robust conversations. But again, as my role in professor of practice, it also involves my role at our Center for Health Equity. So one of the things that we will be doing is they'll be coming over to North Philadelphia to see how we operate our Center for Health Equity in a community that has some of the highest rates of health disparities. Also, you heard representation. So in the summertime, I have students from historically Black colleges, predominantly white institutions that spend the summer with me. So they learn about Stop the Bleed, they get CPR training, they learn about social determinants of health and how they impact health outcomes. On this particular trip, we were taking a tour at the University of Pennsylvania so they could see a medical school and see what they have to aspire to be. And they also worked alongside our doctors this summer and they received a stipend. It was a great summer program. Here's some medical students at Jefferson that whenever they get a free moment, they're always coming over to the Center for Health Equity to help patients fill out paperwork, to shadow, to get more hands-on with doing vital signs or whatever they can. And then again, I have an opportunity to continue the national presence that we were able to build during COVID with the Black Doctors Consortium. And here I'm on the Today Show and I'm talking about my book, but more importantly, talking about COVID and flu. And I'll remind you guys, if you haven't gotten one, I got one in each arm most recently, that it's time, especially as we're going into the season with Thanksgiving and people traveling in and out. And so I'm going to stop there. This is the way you could reach out to me. I so appreciate your attention. I'm looking forward to the upcoming questions, and thank you.
Thank you, Dr. Stanford. First of all, I want to thank you for joining us, but I also want to put in an unabashed plug for your book, which I just read. It's remarkably compelling, and I'm a great lover of stories, and I think that it's really wonderful the way you built your case around the stories that you're telling. So can you talk a little bit about why it's so important to hear those stories? I mean, to get the narratives right, and not, I mean, the data is important. That's all the real stuff. Well, it's not real, but I mean, but then why are stories so important?
Well, I mean, everyone likes a good story. You know, we like to listen to a story when you're a child. You like to watch a movie, which is basically a theatrical demonstration or illustration, if you will, of a story. And so right now, while people are enamored by or they want to learn more about what we did and how we did it, I decided to be very vulnerable and transparent in this story, to use my life as an example, because right now everyone is seeing all the good and they're like, man, you know, she's a CNN hero and she worked for President Biden and all of these things and she built this health center, but you don't know the barriers and the hurdles that I had to cross to get to that. And I don't want to be seen as super person, you know, I want to be seen as person who worked really, really hard. And yes, it's hard to attain what I've done, but some of it was not necessary. How about that? Some of it was just frank sexism, racism, and discrimination. And I want to call it out because it's not from 50 years ago or 100 years ago. It's in my lifetime. And I thought that that would resonate with educators. It would resonate with students, patients, and everyone could see a bit of themselves in the story that I tell.
Yeah, I think that's really important. I mean, there's so much of an attack on what we call DEI these days, and some people talk about structural racism or systemic racism, but I don't think people really understand that it still exists at the level that it does today. So I think that story is really critical and sort of getting beyond that sort of the abstraction of sort of big words to the reality of what's still happening in our cities and all over the place. So that story is really important. So I live in Philadelphia and I'm very familiar with the Philadelphia medical system, and it's a very sophisticated and excellent medical city. But I'm wondering the obstacles you faced in getting the work that you have done, getting it done. What would you say to people who live in some place like, you know, Alabama or the Mississippi Delta, where they don't have those kinds of resources even? I mean, how do people accomplish even a fraction of what you've done in places where they simply don't have power, resources, or, the ability.
I think that this is where the data matters, and knowing what conditions are most prevalent, and which ones impact the most people, both for adults and children, both for men and women. And one of my attendants used to say, how do you eat an elephant? A little bit at a time, right? And so thinking that you can solve every problem will probably have you feeling pretty downtrodden, right? But focusing on an area, especially one that you're passionate about, you'll go a lot further with. You find people who have similar thoughts. You sort of find your tribe, if you will, because then there are people driven to do it. And then there are also funders that are driven to help you. Certainly for state government and federal government, the data is important for funding and for sustainability of whatever your project may be. And that's just how you keep it going. But probably the most important, I would say, is the trust from the people. And sometimes people don't want to go to a doctor or see a healthcare professional until they have one foot in the grave. And that is because of sometimes the lack of respect for our healthcare system. And so the trust is important, and how you develop trust with a community, particularly a community that's impacted, is you have to be present and proximal, close to them, and persistent. You have to go to them, because the first time you go, people are just going to sort of look at you. They may not want what you have to offer, but to show that you're committed to helping is how you start to gain the trust. And so I won't say it's easy, but every area is different. And so knowing your community and also asking the community what they want. You may say breast cancer is what I want to focus on. And someone may say to you, well, everyone I know has died from a heart attack. Maybe that's where you focus. And after people focus on cardiovascular disease, then you can bring in the other conditions. So I would say trust, knowing your audience or knowing your community, and making sure you're giving them what they need and want, as opposed to you coming in and saying, this is what you need. Of course, having the data, and then in order for whatever you're doing to work, it needs to be sustainable. So that's where the money comes. And depending on how large or small it is, there are different funding sources. So that's what I would say.
Thank you. We recently, over the last 2 years, we've done quite a bit of work with a group in South Central LA in the Watts community. And that's another city that has a lot of medical resources, but the people in that community do not feel those resources are available to them. And you talk about that, about people not being able to get appointments, or not even being able to get to things. So the thing they most wanted to know from us was, how can we be more effective advocates? How can we get our messages to the people who will actually act on what we're trying to talk about?
Absolutely. Absolutely. So what I tell folks a lot of times, because I get those questions too about I'm trying to get an appointment, is I tell them to schedule it. Just schedule your appointment. Give them all of your insurance information, whatever it is, get on the books. And then once you're on the books, that's where you can come in, or I can come in, and we can pick up the phone to call. So sometimes if I call and say, oh, you said you'll see Mrs. So-and-so, well, let me use something else. Let me use an imaging study. I see so-and-so is scheduled to get their mammogram in February. Well, she has pain now, and she has a mass now. By February, it may be further out, right? Then you can get on the cancellation list. Then you can get on the wait list. They may even say, well, on Wednesdays, we tend to have more people cancel. If you're here, we'll take you, right? But first is getting the appointment. Now, it's unlikely. I usually don't get people saying they won't even schedule me. I more so get my appointment is so far out, and people are like, oh, that's too long, and they hang up the phone, right? I tend to do that too. Oh, I'm just going to look and find another doctor. No, you put your name on multiple different physicians that can potentially treat what you need or get that primary care doctor, and they all have cancellations, every single one of them. And so that's sometimes how you get in. And then also the advocate calling for you and pushing for why it needs to happen sooner than later. And then when they say, I don't know what to tell, then that's when you say, well, what am I supposed to tell my client? Or what am I supposed to tell this woman? She's doing the best she can. We are supposed to help her. So you bring that person in, like we are supposed to be the ones to help her. So how can we do that? And then they may say, oh, so-and-so takes walk-ins or so-and-so around the corner. Like the health places usually know where they can send people. And how do I know that? Because they send them all to us. They send them all to us when they're booked or whatever. They usually, or when they run out of vaccine, that's a big one. Or when they say they're only taking private payer insurance for the vaccine, that's when we start getting a lot of people. Yeah, I'm a patient over at so-and-so, but they sent me over here to you to get my vaccine, right? Because they know we don't turn anyone away.
So the next pandemic is somewhere around the corner. I don't know whether it's going to be avian flu or something we haven't ever heard of yet. Did we learn anything in COVID? Did you learn any? I mean, I know you learned a lot, but will we do anything better, or have we sunk so far into our polarized world?
Well, I can say if it happens in my lifetime, absolutely we'll be doing something better. I mean, I think the one thing, the biggest takeaway is that your least, your lost, your most vulnerable are going to be hit the hardest. People who have private insurance and can text and call a doctor, like in their contacts, they're going to figure it out. They really are, right? The folks that you give the list of eligibility criteria to get tested or vaccinated, they will figure it out. But your folks that are going to work every day that can't get there at the scheduled hours because you close at 5 or 6 and they don't get off till 8, those are going to be the ones that are hurting. And what ends up happening is if you don't take care of the ones that need a safety net, they're going to be the ones transmitting the disease at the higher rate. They're going to be the ones filling up your emergency departments and your ICUs. So even though you have great personal choice insurance, it's not going to help you get into an ICU if you need it, if those beds are filled with the people that we didn't take care of. So what I would say first and foremost is you got to go, and you'll see the trends. You can even predict before it happens where it's going to be most pervasive based on the type of virus and if it's more in congregated, congested settings. You can figure it out, So I think that the biggest thing is we go to those who need a safety net, those who are most vulnerable, and those who will be disproportionately impacted. And you put more resources there. Everybody gets some, but you put more resources there because you want to quell it and you want to decrease the spread before the horse is out the barn and you can't catch him.
Thank you. So one sentence, or many sentences in your book, but one sentence that really struck me was the one, I'm paraphrasing a little bit here, but where you said, I couldn't be angry about everything. It wasn't helping anybody. I had to turn all this into action. So we're looking at today's world. We won't go too far into what today's world looks like. But what does health justice mean in today's world, and how can we get past being angry and frustrated?
Yeah,
but do something that'll make a difference now?
So, I mean, for me especially, I turned a lot of the disappointment and the anger into first listening and comforting others. I think a lot of the younger ones, and I say younger, including my own children, up through the 20, the 30-year-olds, and for that matter, some people old enough to be my mother. I spent a lot of time comforting and reassuring them that we're going to be okay, right? that people will find a way, that we need to be planning now for the person impacted by the abortion ban. We need to be preparing now for the person who's going to lose their benefits because of the Affordable Care Act. Institutions are going to have to beef up some of that charity care that they offer, and it can't be substandard charity care, but you need to get ready. I told my team, we're already doing it. Fortunately, we are not being funded by the federal government. We're not being funded by some of these programs that only care for a certain population. And so we provide and we see everyone, whether you have insurance or don't have insurance. And so, in fact, I don't even know what type of insurance my patients have. And is it hard to be sustainable? Absolutely. Am I hustling out here every day to make sure we can provide that care and turn no one away? Absolutely. But it can be done. And perhaps what you will see are more centers and more medical offices following the model that we employ, because we won't have to change anything based on what is happening with our new leadership. I think, if anything, we may need to expand our services, and the private sector and community engagement is how you effectively get that done. Because the government support all depends on who's in charge. And I think that's what I learned the most during COVID. If we had waited for the CARES Act to be passed before we acted, more people would have died.
So I guess just to wrap it up, I mean, can we have some level of hope that we will make some progress in achieving health justice in this country?
You know, I believe so, but the hardest thing to change in health and in medicine, and any sociologist or someone will tell you, is behavior. It's behavior. You know, it's something that's taught. It's something that we learn from our parents, I think, or from whomever raises us, that sort of looking in the mirror, being your own moral compass about what's good and what's right. You know, I use this acronym, acknowledge bias, right? And what I mean when I say that is that you have to acknowledge that the things that have happened in this country and why the field has not been level is because one group was able to create generational wealth while the other was only allowed to create generational grief. It doesn't mean that you were the one responsible. You were just born. You didn't know which side you were going to be born into. But what you have to acknowledge is the generational wealth group has been able to grow and prosper, and their children and their children's children have been able to create businesses and be homeowners and have everything the American dream can offer, whereas the other was not. And so you have to acknowledge that we all come into this world not knowing which one you'll be stratified to, and that some were benefited and some weren't. Then the B, acknowledge it, is believe that. A lot of people believe that the situations that people are in are their fault. They should have worked harder. It's not that simple when you have government-driven programs like redlining, just one, for example, that really important people to live in certain parts of the United States. So it's acknowledge it, it's believe it, it's then identify. What can I do as an individual? What can I do as an institution or corporation to eradicate bias and improve health disparities? And again, am I part of the solution or am I part of the problem? A is act. Once you identify it, what are you going to do about it? It's not enough to talk about it, write papers on it. What are you going to do about it? And maybe you are the person that does the research, but partner with someone who can carry through your findings. And last is S, is you share it. You share what worked. You share what didn't work. You spread it widely, right? And then you repeat. So it's acknowledge bias. Acknowledge, the B is believe, the I is identify, the A is act, and the S is share. So do I believe? Yes, but so much of it starts with the individual.
Thank you, and thank you so much for being with us today and for sharing your work and your inspiration as well. And again, I want to encourage everybody to read Dr. Stanford's book, which is take care of them like my own.
Yeah.
It's very powerful. Thank you so much, Dr. Stanford.